Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Johanna Richey. Hi, Joe.
Hi, Jeff.
How are you doing today?
I'm doing excellent.
Fantastic. Well, we have a phenomenal guest today, an icon in podiatric medicine, Dr. Alan Jacobs. Dr. Jacobs, welcome to Dean's Chat.
It's nice to spend some time with you and Joe, and hopefully we'll have some fun this session.
We're going to have a lot of fun. And if it's okay with you, let's go with first names, Alan, Joe, and Jeff.
That's fine with me.
All right. Let me give a little bio here on you, Alan. You're a 1973 graduate from the Pennsylvania College of Podiatric Medicine. You, in 1975, completed your residency at the Senior Clement Kern residency program in Detroit, Michigan. We've got some common themes there. You're board certified by the American Board of Foot and Ankle Surgeons. You were a residency director for 25 years. At one point, you were the scientific chair for APMA. You are in the Podiatry Hall of Fame. Congratulations on that. You have published 80 articles and 17 chapters on podiatric medicine and surgery. You've presented over 1,000 lectures around the country. It's just an honor and a privilege to have you on Dean's Chat. Welcome again, Alan.
Well, thank you. It's good to be here.
It's great. So Joe and I have been doing lots of interviews, and we've been interviewing current residency directors, past residency directors, and so you're gonna be categorized on our website under deans and leaders. How's that sound?
I'll accept that.
All right, we'll run with it then. So, Alan, how did you find yourself going into podiatric medicine back around 1969, 70 or so?
I worked my way through school as a scrub nurse and a retractor holder. I actually started working in hospitals and operating rooms when I was 13 years old. And I thought I was a walk-on to Temple Medical School, so I only applied to Temple. And I got put on the alternate list. So I was looking for something to do for a year to go back to Temple Med School, and a general surgeon who was quite well known in Philadelphia that I worked with quite frequently in general surgery told me about his partner. They co-owned a hospital, believe it or not, in Philadelphia, and they owned an ambulance service together. And he told me that this fella had, to use his phrase, the best hands in the business. And I didn't know a thing about podiatry, so I watched him a little bit, and I thought that podiatry school would be a good way to kill a year. So I went back to Temple Med School and went into that first year. And I was very lucky. I was there during the time that Jim Bates was the president of the school and Charles Gibley was the dean. And the old Pennsylvania College of Podiatry was literally across the street from Pennsylvania Hospital. And they were able to recruit an unbelievable faculty. And the dean had told this faculty they wanted us to receive the same education as would be given to the medical students that they were training at University of Pennsylvania. And each of the faculty members started the sessions by telling us that was their instruction, and those were the standards to which they would hold us. And after that first year, I enjoyed it. I thought this is a profession that likely had a future. And so I never reapplied and stayed and saw my way through to the very end, to this day, where now I'm just an old guy in podiatry.
Well, I know that I was trying to reach you a few weeks ago. You told me I have patients and a bunch of surgeries scheduled. And so it sounds like you're still going at full speed.
I am. I'm still full-time practice, and I still keep my hand in the OR working with residents. I still enjoy that, although I've cut back quite a bit on what I do. And one nice thing about being older is that you could pick your battles. And so I tend to pick my OR fights a little bit more carefully than I might have when I was younger.
All right. That sounds good.
I've learned to say no.
Hey, that's the most important word in the English language, I think.
Well, it can be. And I think as you mature, I always tell the residents that you'll appreciate this as you go on through the years, that you'll start to pick your fights and realize there are some battles that maybe are best left unchallenged by you, and let someone else go ahead and do the dirty work.
So in some of the interviews Joe and I have done, whenever the Temple School of Podiatric Medicine or the Pennsylvania College is discussed, Dr. Ghibli's name comes up. He truly, truly is an icon also. Was he a mentor to you at the time?
No, he did none of the teaching. He was a PhD, I believe, I may be wrong, in embryology, but he made it clear to us that those were the standards he held not only the students to, but the faculty members to. So those faculty members, as I say, whether it was psychiatry or internal medicine or whatever topic, we read the same Cecil textbook at the time that the medical students did. We did the same Robbins textbook of pathology. We participated in the autopsies. We did the rounds. And we were held to the same standard as the medical students from University of Pennsylvania were. And this was all Dr. Ghibli's doing with Dr. Bates' help. And they brought us an unbelievable, I was so lucky, we had an unbelievable faculty. For example, the famous orthopedic surgeon, Richard Rothman, who went on to form the Rothman Institute, just a giant in international orthopedics. We had him as our orthopedics instructor. And that was just one example, and I could go on and on and on. We had Michael Sheff as our biochemistry professor. He worked with the people who developed the Emden-Meyerhoff harness pathway. For those of you that want to get your stomachs upset, you may remember the Krebs cycle. And we had a faculty that was just like that. We had the chief of neurology, Henry Schuda. And that was a perfect example. We read Frank Elliott's textbook of neurology. He held us to the same standard. When we made rounds, he didn't say, I don't expect you to not understand this because you're a podiatrist. We had to answer the same questions, and you either did it or you didn't. But we had every opportunity to learn. And I took the time and developed a philosophy that stood me in good stead. And that was I would go out of my way to learn the medicine, the same as a medical student would. But I would also do a second look and say, where would this apply to me as a podiatrist? In other words, let's say neurology. I would say, I'm going to learn about multiple sclerosis. I'm going to learn about dementias. I'm going to learn about upper motor neuron diseases. But I want to master two circumstances. One would be if a patient comes to me as a doctor with a known diagnosis, I needed to know the lower extremity manifestations of that disorder that I might be asked to evaluate and treat. And then I looked at it a second way, which was signs and symptoms of these diseases in patients who were previously undiagnosed that could be manifesting in the foot. You know, a classic example would be the patient with diabetic neuropathy preceding the diagnosis of diabetes. And I made that my mantra going through podiatry school. And as I say, I was so lucky to have been there at a time that we had an incredible faculty that was dedicated to giving us the best education. I was very fortunate to be there during those years, 69 through 73.
That's incredible. Joe, it sounds like what we're trying to replicate in Arizona.
Yeah, absolutely. And again, it's such a testament to when we start thinking about the history of the profession, how far we've come. And it's because of faculty like yours, Dr. Jacobs, that said, hey, look, this is what we expect from you. And we're just going to keep raising the bar. And I feel like our profession has come leaps and bounds over the last 50 years in terms of scope of practice, the parity that we are now experiencing. And well, one of the things that has been so fascinating listening to these podcasts is getting a glimpse at that process and that progression. And, you know, there's still ways to go, but having the appreciation for all of the work that people have put in to get us here. You know, our young students come in and, you know, it's kind of expected. Of course, I'm going to get out and I'll have hospital privileges. Like, why would I not? And so I think that this is such a beautiful discussion about the educational component. Like, of course, we're going to hold you to the same standard. And that wasn't always the case. And it was, you know, we want this to be a profession that people are proud of, that represents us as physicians and surgeons. And you cannot do that, to your point, Alan, if you're not treating the whole person. And even though medicine has become so specialized, that doesn't excuse you from knowing and understanding the pathophysiology for how these things happen, and then being able to apply that to the region that you're working. So I think that that's such a beautiful story.
Oh, yeah, things have changed. For example, as I said, I worked my way through school as a scrub nurse. And when I went to podiatry school, it was clear to me that I needed to be scrubbing more orthopedics and more vascular work. Although vascular surgery, when I was working my way as a scrub nurse, wasn't that developed. There were very few procedures actually being done. So I was working at Albert Einstein Hospital in South Philadelphia at 5th and Reed, and I was getting ready to scrub a case of diastomatomyelia with a very well-published orthopedic surgeon at that time. And we had residents, and I was loaded to bear. I had read Mike Campbell's Orthopedics. I studied up on diastomatomyelia, and we had a first-year orthopedic resident, and we're at the scrubbing, and the resident could not answer any questions that the attending was asked. And this was a pretty high-powered academic. And so I kept spitting out the answers. And he finally looked at me and he said, "Let me ask you a question." He said, "Are you expecting to work at this hospital and do surgery here?" And I said, "Well, I'm hoping to." And he said, "Let me tell you something, son." He said, "If my own child was a podiatrist, I would never grant them privileges to work in a real operating room." So that was the environment as it was many years ago. And I had mentioned in a little piece I wrote in PM Magazine, not that history makes a difference now, but I remember the days when a podiatrist could not get on the staff of a decent hospital. And when I went back to Philadelphia finishing at Kern, podiatrists were almost exclusively relegated to little teeny community hospitals, but you would never get on the staff of a large hospital. The only podiatrist who was working at a major hospital at that time was our co-chief of surgery, Lou Newman, and he was at a hospital called Rolling Hill Hospital. And other than Lou, you really were stuck at these little teeny hospitals, and because there was no, it was the Selden report coming true. Most physicians had no interactions with podiatrists, and anything they heard about our profession came from hearsay, likely naysayers about our profession. But over the years, what happened was you had these well-trained individuals, knowledgeable individuals who went out into their communities and I believe built the profession at the ground level. In other words, I think individuals went, demonstrated their competency, and they're the ones that I think made podiatry into what it is today. I don't think it was a national effort. I don't think it was anything in particular that perhaps the APMA did. I think it was ground level wins, people like Jack Schubreth going out into the community, or the Guido Laportas, or whomever, and showing competency, showing capability. And in the end, I tell the residents, that's what you have to do, that don't rely on anyone else to win your battles. Be competent, be caring, show that you're going to deliver effective, cost-effective care, and that's what's going to win you the referrals and win you the patients. It's not a political issue anymore. It's generally a competency issue, and they're going to evaluate you one-on-one. And I think that's what brought our profession to where it is now. The people like the Earl Kaplans and the Irv Canets and the Dalton McGlamories, and we could go, the Arthur Helfans. I mean, this list could go on and on and on. There are, thousands and thousands of them, but they went out, and every now and then you impress the right person at the right time, and podiatry got that jump. Mm-hmm. So I think we've pretty much arrived for the most part now.
I think so. So can we go back to the Kern days? I've been so waiting for this interview, Alan, because I heard stories like you when you were a resident at Kern, you were also moonlighting as a comedian. Is that true?
Well, there's not the time, not while I was a resident. No.
Okay.
There was no time at Kern. Kern, they were pretty strict. They had that old time sit on the resident attitude. And for example, on Saturdays, you were supposed to be in that hospital, and they would call you just to speak to every resident, if for nothing else, just to assure that you were there. The thing that Dr. Kaplan made clear to us was that we were fortunate to have a residency. Back in that day, residencies were not easy to come by, and good residencies were even tougher to come by. And Dr. Kaplan, at the end of the residency, met with you individually. He sat down, shook your hand, gave you the name of someone that you could rely on to go into the community and help you if you had some problems. Although it was kind of funny, when it came to Philadelphia, he said, I really don't have anybody in Philadelphia. He said, there's a guy named Ganley, but I'm not sure we could trust him or not. But Dr. Kaplan made it clear to us that our job was to go out, start residencies, participate in education, grow the profession. He made that very clear to us. And if you think about the people we worked with, Jeff, they were both academics and politicians at the same time. The Irv Cannets, the Earl Kaplans, the Robert Weinstocks, the people like that, they had bona fides not only in academics and clinical practice, but when needed to be, they fought the political battles too. And so they made it clear to us, this is what you had to do. And in those days, you had to do it. I mean, when I came to St. Louis, I had to get lawyers and battle my way into a number of major institutions here to get podiatry where it got. And I wasn't the only one that grew the profession in the city. As I say, it was graduating individuals who went out, demonstrated their competency, demonstrated their care for patients, and won people over by saying, these people are very well trained and they're quite good at what they do. And you start getting the referrals and building the profession in that way. So the people at Kern were quite motivating in that regard. And there always was something special, as I say, about Dr. Kaplan being in that room. We would be debating what to do with a particular case and how to approach a particular case. And Dr. Kaplan would walk in. He might have never even seen that patient before. And he would take a glance at that foot, look at the x-ray and say, here's what you're going to do. And 9 out of 10 times, probably 99 out of 100 times, he was correct, and the outcome was a good outcome for the patient. So it was special being there in those days.
Oh, I'll bet it was, because when you were there, they had just built the new building on DeQuinder, right?
We were the first group at 8 Mile Road in DeQuinder, and that was what they were like. They gave us a closet with a bunk bed to sleep in. And when the hospital first opened, because of Michigan regulations, only half the beds could be used for the first 6 months or so. So we had a whole half of a hospital that was empty with empty beds, and the nurses were instructed, do not allow the residents to sleep in those beds. And they gave us literally a walk-in closet with bunk beds, and that's where we had to sleep. So we were part of that first group for sure.
Alan, I remember that walk-in closet right behind the nursing station on the second floor.
Yes, it was. It was on the other side of the wall, right behind the chief nurse's office.
Absolutely. Just for full disclosure, so I also did Kern. I think our listeners know that, but I graduated in 93, so I was a little bit behind you. Alan, can you tell some more stories about Kern? I mean, I worked with Dr. Weinstock, Dr. Kirschenbaum, Dr. Canet. It was just an incredible learning environment for our profession at the time.
Oh yeah, when we were there, Dr. Kaplan made it clear to us, you learn from everyone. We had to do the anesthesia. So back then we had to start our own IVs, and we used to neuroleptic patients using Inovar and Valium. And the chief of anesthesia, I don't know if he was there when you were there or not, he would just sit there, read the Wall Street Journal, check on his investments, because we had to do everything. We had to start the IV, administer the Neurolept, then go ahead and run down to the foot, give the block, run back up. And his name was Duke Diocampo. I don't know if he was there when you were there.
No.
And he just watched everything going on. And he was so impressed, he actually gave up anesthesia and started doing foot surgery.
Oh, no way.
And that was the way it was there. Kirschenbaum, the listeners would know him, but Stu was a Jewish kid from New York State. He was a Golden Glove semifinalist in the state of New York, and there's not too many Jewish guys that you're going to find in boxing. I guess somebody would say Benny Leonard or some old boxer like that. But realistically, Stu fought his way as a younger guy, went to Detroit, did very well as a podiatrist, and he became chairman of boxing, the boxing sports commissioner for the state of Michigan. And he would not infrequently go and judge. You'd see him judging heavyweight title fights, and he was part of Don King's stable at the end. And he would sometimes bring Tommy Hitman Hearns and some other famous boxers to Kern for us to meet. And he was very, very, very funny. And he was a tremendous black humorist. For example, one time we were working on a patient, and we gave Minivar and Valium. I don't remember what we were doing. And Kirschenbaum goes to the head of the table, and he takes a towel, paper towel, punches a hole in it, and puts the patient's hand through the towel, puts it on the patient's chest, and he wakes the patient up. And he tells him, "Listen, we made a terrible mistake. I'm really sorry about this. I confused you with another patient, and I'm afraid we removed your right arm." And the patient, half out of it with the Inivar, he goes, "Oh my goodness, no, Dr. Kirschenbaum." He says, "Don't worry, I'm going to sew it back on before you wake up." He goes, "Oh, thank you, Dr. Kirschenbaum." Another time we were taking out a fifth metatarsal head. Back in that day, that's how you treated calluses under the fifth metatarsal. You were taught to remove the metatarsal head. And we had a student on rotation watching the case. Didn't know Kirschenbaum at all, of course. And he takes out the med head, and the student says, "Does it ever come back?" Meaning the callus, and Kirschenbaum looks at him and just says, "No, as long as you put enough postage on it, the med head will get there and the pathologist will keep it." But he was a very competent doctor, very good doctor, but he was very funny at the same time. And there were a number of people that were like that, that were self-made, because these people learned by working together. Back then, there were no residencies, or very few residencies. And podiatrists worked together. There was a real spirit that went through this profession. And you'd see podiatrists working together in the OR, counseling with each other on cases. I remember the days when I was popular as a lecturer, for example, in Massachusetts, and I would go to their local society meetings quite frequently. And if a hospital was opening up, you'd see an announcement made, and somebody was saying, "Here's where you send your applications in, and here's how you do it." And the spirit was to get everybody in. Nowadays, at times, I think people tend to want to keep it for themselves and maybe not share that information. But you used to see a lot more friendship, I think, not as much isolation between practitioners as perhaps you see today. Much more spirit of podiatry working together as a whole than I think maybe I sense is out there in today's world. But part of it is, as Joe mentioned, in today's world, these kids get a great residency experience for the most part, and they go out and they have hospital privileges available for them, and they don't have that same sense of threat to the profession as we did, because we were starting and building something and we needed to work together to accomplish that. Today, that's not necessarily true. I mentioned in PM Magazine in a piece I just wrote for them that I remember very well one night driving down Route 40 here in St. Louis. It was dark, and I passed 3 large hospitals, and none of them allowed podiatrists on staff at that time. And these are 3 major hospitals I drove by. And I thought to myself, I'll bet this is what Detroit looked like to Earl Kaplan when he first started practice. Now I look at today's world here in St. Louis. Every hospital has podiatrists on staff. Every staff has very decent hospital privileging for the most part. There's no limits. You have occasional hospitals here and there that still have some old-time limitation, but I remember the days when there were only 3 little hospitals that would let you on staff here. So these kids come out now and they immediately are granted staff privileges, and they could go ahead and start earning a living as they wish to do. So they don't have that same sense of needing to work together as a profession, because a lot of what needed to be accomplished has been accomplished.
No, that's well said, Alan. That must. How does that make you feel, breaking open that whole St. Louis area? Because you were this guy from St. Louis that was pushing the profession.
Well, if you want to hear the story, how things can happen, and I'm sure the people listening to this can give examples. The CEO of a major hospital here in St. Louis happened to have been a patient of mine. He's now deceased. And I had an older woman who had an ingrown toenail done. That's all she had done was a P&A. And she's sitting in the chair and I'm following her. And she said, "You should come over to our hospital." And I said, well, I would love to go there, but they don't let podiatrists on staff at that hospital. And she said, they would if my minister told them to. My minister is the CEO of the hospital, blah, 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 Deaconess Hospital it was. And so I said, well, you go ahead. You tell him that Dr. Jacobs wants to go there. She said, I will. And this woman worked as a volunteer filing x-rays in the x-ray department. That's all she did. It wasn't a week later, I get a phone call from the CEO of the hospital asking to meet. And he became a patient of mine. And next thing I knew, not only do we have a podiatry staff there, we had a residency and we had our own clinic over the objections of a very large and dominant orthopedic department. So one day, he's in the whirlpool. Those of you that are old enough to remember the whirlpool days, yes, I had one in the office. And he said, Alan, because of this hospital, Deaconess, these other hospitals in St. Louis are going to open up to podiatry. And I said, why do you say that, Jerry? And he said, because we administrators meet with each other the same as you podiatrists meet with each other and ask us all the time, how's it going with podiatry? Are they fighting in the hallways with orthopedics? Are they shooting at each other? What's going on? He said, no, it's worked out quite well. And so this hospital started to open up. Then we had an intern in a resident in family medicine, again, an ingrown toenail. That's all this was, and did a P&A. And he asked why we weren't at another major growing hospital in this city, which is probably one of the dominant hospitals now. Hospital systems. And I said, well, they don't let podiatrists there. And he said, let me talk to my dad. His dad was a neurosurgeon, chief of staff. And because we did a P&A on his son, the next thing I know, I'm meeting with the CEO. Same thing happened. The hospital opens up. And so, it wasn't just me. It was all kind of odd coincidences and things that happened. But still, the podiatrists who graduated programs and went into these hospitals had to carry out good care and impress the staff, or that growth would not have continued. So it's a tribute to the profession as a whole. And I go back to that Selden report that changed podiatry quite a bit. And they talked about the fact that we needed more interaction with the medical community, because way back when, podiatrists were like dentists. They were almost exclusively office-based, and there was not that much interaction between MDs and podiatrists, and there weren't that many DOs at the time, but I'll say DOs also and podiatrists. And now, of course, there are. So things have changed dramatically in our profession. But that's how it grew here in St. Louis, and in no small part because of an older African-American female who was a volunteer filing x-rays in an x-ray department, and a kid that needed a P&A done whose father happened to be a neurosurgeon.
Alan, those are priceless stories. I just love them. Joe, could you imagine going through that today? It's incredible.
Yeah, no, absolutely. And that's why I think it's so important to capture this conversation, right? There's a really great book by he's a computer engineering professor. I think he's at Georgetown, called Be So Good They Can't Ignore You. His work is more in terms of getting off of technology. But anyway, his name is Cal Newport, for anyone that wants to look up the book. And what I think is really interesting that's common in this theme is this idea that when we go out into a community or into a hospital or into a lecture series, we are bringing with us an entire community. And there is responsibility there. There is accountability there to be the very best version that we can possibly be. And that's not to put a bunch of pressure on everyone. Hopefully it's a motivation that, yeah, it's hard to go through 4 years of medical school. Yes, it's hard to get tested alongside our medical colleagues on things that we're like, I'm never going to be doing this. But you may not be managing their heart failure, but you're going to be managing their lower extremity while they are in heart failure. And so all of these things are relevant. And so I really love, Alan, that you talked about your perspective on it was, how am I going to see this for the foot and ankle? Like, where is that going to become relevant? And I think that's I love that. I'm going to totally steal it and start feeding it into our students to kind of help them kind of framework it, because no specialty or even just general practitioner these days knows everything. Medicine is too diverse now, right? There's so much out there. There's so much that we know. There's so much that we don't know, that everything is becoming compartmentalized. And that's good for a lot of reasons, but it's also a little bit dangerous in the sense that the right hand doesn't always know what the left hand is doing, because our healthcare system is pretty fragmented. Over the years, what are some of the things that you've seen in terms of changes to the healthcare system and how we deliver care to patients?
Well, obviously, I come from a different generation. My generation was office-based. When I finished my residency, I went back to PCPM, and I was full-time faculty, half-time in medicine under Tony Kadawa, and half-time surgical faculty under Guido Laporta. But then I worked evening hours in private practice, because back then you saw patients at night. So I would see patients from 5 to 9. We saw patients on Saturdays in the office. And I started with the private practice centered concept, which was dominant. And I don't even remember there being that many medical complexes at the time, other than those directly associated with a hospital. And obviously things have changed now. We all know how it's changed. And I think residents need to be, it's kind of funny, because when I want to talk to them about private practice, I don't know that it's relevant. I look at the graduates of our program here. It's not my program. I participate in it. I'm no longer a residency director. I'm lucky now. I'm like the grandparents. I get to play with the kids for a while. And then when their diapers get dirty, I turn them back over to the parents. And so I'm not inundated with paperwork and all that. But it's hard to talk to residents about private practice, because I'm not sure private practice as we know it will be there in another 10 years. The kids that come out of this program are working for hospitals. They're working for medical groups. They're working for orthopedic groups. So the issues where one had to be clever and witty and have a business sense to run a private practice aren't as pressing anymore as it is to understand how to negotiate RVUs or negotiate vacation time in your contractual obligations to whoever is retaining you to work. So it's a different environment now. And I think people have changed. People, you look at the growth of urgent care centers here in St. Louis. You can't go 3 blocks without passing an urgent care center. And it's almost as though people don't value the doctor-patient relationship anymore. You become almost a commodity provider. And that's my ankle hurts, do something about it. And I don't really care too much whether we have a relationship or not, because people run to urgent care centers and they don't know the first thing about the doctor that's in that urgent care center, whether good or bad, or whether they're ever going to see them again or not. So I think it's changed largely in that regard. I think the mindset is to prepare students and residents for a future more in corporate-based medicine, because that's what's happening. And you've got health systems such as Kaiser, Joe, where you did your residency, that dominate not only a state now, but starts dominating adjacent states and then become national. I mentioned the Rothman Institute earlier. They are a dominant orthopedic force in initially Philadelphia, but now Pennsylvania and Delaware and New Jersey. And healthcare systems are branching out into adjacent states. And here in Missouri, for example, our state's basically now essentially been divided in half between 2 healthcare systems that have merged, and you're either going to play with them in the sandbox or you're not. So that's been the biggest change, I think, in terms of healthcare, is the corporatization, if you will, of healthcare. And I don't think that's going to change. I think that's going to continue.
I think that's really very well said. And I'm curious your take on the benefits and or limitations of that.
Well, I don't know that there's tremendous benefits from my point of view. I have, I'm old, so I have old patients that have been with me for many, many years. And so they appreciate the doctor-patient relationship. They appreciate the fact that when they go to the front desk, the people that work in this office know about their children, know about details of their personal lives. And they, we decorate the room for every holiday. We just took down St. Patrick's Day. We put up Easter this morning. And I mean, we decorate. We don't sort of decorate or have one little thing. We decorate for Christmas. We decorate for everything. And the patients enjoy that personal touch. They enjoy that feeling that they're not in a sterile doctor's office. But I think that is clearly disappeared. When I go for my own health care, I go over to WashU School of Medicine, and they're great doctors, but it's very sterile. And the rooms are very clean, and there's nothing personalized about it. You sit there, the MA comes in, you're taking the same drugs, let me get your vitals. Then the fellow comes in, pretends like they know about you. Then they go and rat you out to the attending. Then the attending comes in and pretends like they've been studying your chart for the last 6 months. And it's very, very sterile and clean. And I think that's what people are accustomed to now, or are getting accustomed to. But and I don't know how it's going to play out in podiatry. I mean, you talk about a profession that's well suited for the future. Look at this country. You've got an explosion of diabetes. The geriatric population is the largest growing population in this country. You've got people participating in sports left and right. And so what better three populations could you want for a profession for potential patients than podiatry? So this profession is well suited for the future. I just don't know how it's going to blend in with corporatization of medicine, which is become rather impersonal. And now everyone, of course, wants to talk about AI. And you know what's going to happen. We're going to have, and you have it at Kaiser. I don't know, Joe, if it was like that when you were a resident. I'm sure it is. But Kaiser has its own rules and guidelines and structure that you must follow for every disease and disorder. Jack used to jokingly say that the Kaiser screen for diabetes was to urinate on the wall and wait and see if the ants ran to the urine. And if they did, it was probably a diabetic patient. And although he said it jokingly, I understood what he was saying. The point was well made. And I fear that some of that's going to come where you're just going to come in, patient says plantar fasciitis, and you're just going to punch in, height, weight, a few other factors, and they're going to tell you, here is how you're going to treat it. And again, I have patients that come in now every day. It wasn't like this 40 years ago, and they say either they've never met the doctor, they meet the PA or the nurse practitioner, but I ask them how they feel about it, and they say, well, if I was really sick, the doctor would see me. Or they say they never see the face of the doctor because the doctor is engrossed in treating the computer and treating the medical record, and they never see the doctor's face. All they see is the back of their head. And they go, doctor, by the way, you better get that mole checked out on the back of your head there. It looks like it might be a melanoma. So that's basically where medicine has gone. And these kids today are computer literate beyond belief. My generation, I had to rely on my wife's young nephew to show me how to use a damn computer when it first came out. I was one of the last guys that still used slides. I mean, I remember going to the APMA National in Chicago with my wife, and I was supposed to give a 2-hour session on infectious disease, and I had my carousels of slides with me. And I remember going to the breakout room where the session was going to be held, and this kid's up on a ladder, and he's adjusting a projector, and he goes, "Oh, you're the one." And I said, "What do you mean?" He goes, "Yeah, they told me somebody was still using slides, so I guess you're the one they were talking about." So, although the joke was on them because when they had their major session, the computer broke down and it ruined the main session. So at least my slides worked. But these kids today, if I ask them a question, within 30 seconds, they could find the answer on a computer. It's just amazing what can be done now. And so I could understand the focus on computers in medicine, and I enjoy using them because it's easy to access rapidly patients' information, but we're losing that personal touch, that personalization. I think that's probably gone.
Nice. So I think I want to jump on that real quick, if you don't mind, Jeff, because I think this is actually, I didn't even know we were going to go here, but I'm so glad that we did. I think some of the most exciting things about AI is this idea that the things that can be procedural and computer-based and take up so much of the physician's time, not their mental capacity, but their time, can be shifted to computer-based functions. But what I think is really important that we don't lose is, as we are teaching and training these generations of residents and students, that process of a differential diagnosis and the importance of that personal relationship. And I know you do a lot of medical legal work as well. So again, there's so many things that we could take this down, but I'm curious, you mentioned AI, and I'm curious what your thoughts are in terms of if you see this being something that will be more beneficial, or in terms of medical legal issues, or do you think that it's potentially starting to open up a messy situation legally?
Getting away from medical legal for a second, I always tell the residents when we make rounds, as you would, which are primarily going to be infections and diabetic patients that are in house, and I always tell the residents, you can't appreciate how important that visit is unless you've been sick and you've been laying in bed. And it sounds like old guy's advice, and I understand that, but it's true. Once you are dependent on other people to make medical decisions about you, particularly if they're life and death, which I have sort of been there, not to be overly dramatic, but it's true, you want to feel that that doctor is caring. And you want the doctor to actually truly do care. And you don't get that with AI, and you don't get that with the computer. Now, I understand that ultimately you want a competent decision made, and it could be the worst personality doctors in the world as long as they're helping you and achieving what you need. I understand that competency is number one, but sometimes it's important to tell a good joke. They say that sometimes the best medicine is a good laugh, and sometimes that's true. And sometimes giving patients hope is important, and letting them know that you're on their side. Now, this could get ruinous too. For example, I had a patient in the hospital one day, and he was going to lose his leg, and there was no doubt where he was going. And I liked the guy, and he said, I really miss laying here, Dr. Jacobs. He said, I miss a certain kind of a breakfast. And I said, really? And I'm trying to think of what it was. And biscuits and gravy. And he said, I really wish I had biscuits and gravy. And he was clearly getting depressed. So I go to the doctor's lounge, and wouldn't you know, they've got biscuits and gravy there. So I told the residents, watch this. We pile up some biscuits and gravy, take it to him personally, and I became his hero. And all the nurses heard about this, and the attending said, you're a real hero to this guy, this, that, and the other thing. A couple of days later, biscuits and gravy are back in a doctor's lounge. And this time I was being lazy. I told the residents, take this to that patient because he really likes biscuits and gravy. Oh, and some slices of bacon, because he was complaining about not only getting 2 slices of bacon. So I piled up some bacon, biscuits and gravy. The residents take it. Next day, I see the attending. He goes, hey, I understand you gave so-and-so biscuits and gravy. I said, yeah, he really loves biscuits and gravy. He says, well, you threw him into congestive heart failure with that. There was too much salt in it. And I asked the residents, who did you give it to? And they gave it to the wrong patient. So I felt terrible. And I went back to see this guy that got the wrong breakfast. And he says, Dr. Jacobs, you're a genius. He said, everybody said you're a good doctor, but I didn't realize you were a genius. Because it was the wrong patient. He said, how did you know my favorite breakfast is biscuits and gravy? So I had 2 patients in house, both of whom love biscuits and gravy. But my point is, that's what's lacking from AI and that's what's lacking from, I think a lot of it today, is that you don't want to be a bunch of automatron doctors. Patients want that personal touch. They deserve that personal touch. And I guarantee that the residents that are looking at their watch and can't wait to get out soon enough, if they were laying in bed and they were ill, and I mean seriously ill, and they would want to feel that that doctor was doing their best and really truly cared about them as a person, as an individual. I think that's really important. And Dr. Kaplan, I don't know if he did it, Jeff, when you were a resident. Dr. Kaplan, of course, in his youth was a great-looking guy. And he used to bring his female patients roses after surgery. So when you'd finish the cases, he'd show up that night and hand them a rose or two for having had their foot surgery done. And it made him a hero to those patients. It was just that kind of thing that I think is lacking in medicine today. And maybe it's a necessity. Maybe people are going to say, look, you know, we have an expanding population and we just can't do this personal thing anymore. And I guess that's understandable. But I just think patients heal better, do better, if they have a confidence that that person taking care of them really does care about them and not pretending to care about them. I teach the residents something that the surgeon I mentioned earlier that told me to try podiatry. I remember I would go to his office and he would see patients till midnight, literally till midnight, sometimes 1 a.m. And I watched him intensely. He was a very successful, well-known surgeon in Philadelphia at the time. And he said, always sit down. When you make rounds, don't stand at the foot of the bed. Always sit down, cross your legs, and be relaxed. Because in that patient's mind, if you sit down, that 2-minute visit in their mind was like a 10-minute visit, and they feel like you were really there and caring for them. And it's just little things like that that I fear we're going to lose with automated medicine. It just worries me.
Wow, Alan, that's awesome. You know, I have a request, Alan. I've got a whole list of questions here to talk about your career. And would you be willing to come back for part 2 with Dr. Jacobs?
Oh, I would do it anytime. I love sharing thoughts with my colleagues. I really do. Anybody that knows me knows that's my style. I think this has been a great profession. I think it is a great profession. And I don't know what value there is or is not in going over history, but I always like to think there's some value to some of this.
Oh, I think there's tremendous value. And
Agreed.
So, Joe, I was going to ask Dr. Jacobs one more question, and then I thought maybe we would wait for the rest for the next part 2. So, Dr. Jacobs, you know Shauna Shapiro, right, at BACO, of course.
Yes.
She's the one that told me that you were a comedian back in the day. So I'm dying to hear this story.
Well, there's not much to it. I did a little bit of stand-up here and there on the East Coast. Nothing much. Actually, you know, the guy that was my hero was my professor, our professor of microbiology, Carl Abramson. He was a high-powered comedian. And because again, it goes back to those days. We had a full year of bacteriology, of parasitology, of mycology, of immunology, of tropical medicine. And he ran a rough show. But being a fellow comedian, I had an appreciation for Carl. And every now and then you'd see a student in the class start with him. And I would just sit there in amazement and go, well, if you ever tried dealing with a room full of drunks and you had to come back quickly, you're going to pick on this guy. And I would watch Carl just slice these people up. And I kept wondering, why would you continue to challenge this guy? But yeah, I did a little bit of that. And you know, I think to be an effective educator, I always had this philosophy. I learned it on a TV commercial, actually. I think you have to motivate people and you have to entertain them a little bit in addition to educating them. And I think that combination is helpful. I know so many good educators that are just too dry and their message doesn't get there because they're slide readers or they're just too dry. So I think you have to kind of blend entertainment with a little bit of that, not too much. I think some of our speakers, maybe that becomes their priority. And, you know, there's times I've sat in a room and said, I didn't pay to be entertained totally. I came here to learn. But I think every now and then you got to look at that crowd. And if you're sort of losing it a little bit, I think you got to put a little comedy in there. And I think everybody likes a good joke.
There's no doubt. Did you work medicine into your routine at all?
No.
Okay. Hey, I've been in the room with you at big meetings where you were carving people up.
I had my day. I'll admit that. The only thing that ever irritated me, honestly, is I'm not a good politician. I understand you were just at the House of Delegates. See, I could never do that because if I think someone is being insincere or lying, I don't have the ability to work around that. If somebody insults me and they say they're lying, particularly if they're doing it for selfish reasons, I just don't have the ability to work with that. And I feel like I have to challenge them right away. That's why I never got involved in politics. I never would have been any good at it. One day when I was chairing, I chaired the APMA national meeting for 3 years. I think one was in Disney, one was in Vegas, and one was in Boston. And we were in Vegas, and at that time, the APMA House of Delegates was not separated from the scientific meeting. It was held at the same time. And I was very upset that my perception was the House of Delegates was taking priority. So they were getting the best rooms and they were getting the meeting spaces. And I was pretty upset about it, but I didn't say anything verbally. And Dr. James Ganley, somehow he knew I was upset. He said, Alan, let's take a walk around the exhibit hall. And he said to me, you any good at politics? And I said, no, I am not. And if I think, and absolutely not. He said, neither am I. But he said, you know something? He said, we need politicians to protect and grow this profession. And he said, you're not any good at it. And I'm not any good at it, but we need people who are good at it. So you got to give them their space too. And so when you've seen me lose it, and I have lost it on occasion, it's only because I feel that the people were being disingenuous. I could deal with any difference of opinion because Lord knows I'm not always right. But if I think someone's willful and malicious and just lying, I just don't have the ability to stand there and take it. One final story would be, for example, I was at the No Nonsense seminar one year, and you may remember dermographs when they first came out. And Dermograph got a bunch of names in podiatry, and they put out a document suggesting that the use of Dermograph was standard of care, which is a legal concept. Standard of care for ulcers that, classically didn't close 50% after 4 weeks. And I was at the meeting and Dermograph had a lawyer who gets up and is lecturing on behalf of Dermographs on standard of care, telling people in the room that if you didn't use a Dermograph after 4 weeks of a ulcer that didn't heal at least 50%, that this was malpractice. And I let him have it, because this was, outrageous. That's the kind of thing I just have not ever had the ability to tolerate. And, 2 weeks later, after that document came out, I got a call from a well-known podiatry plaintiff attorney in Florida asking me to review a case and be an expert witness against a podiatrist for failure to use a Dermograph on an ulcer.
Really?
And so that's how dangerous these kind of things are. And like I say, I just don't have the ability to stand there if I feel someone's trying to willfully job me. Yes, I over the years, I think I have let loose a few times, but I always felt I was justified in doing so.
So
radical honesty.
Yeah, I like it. I mean, hey, we need more Alan Jacobs out there. Alan, I think I was at that meeting. It was in Orlando, wasn't it? Where they had the attorney.
With the Dermograph?
Yeah.
No, that was at the No Nonsense seminar in Ohio.
I think you had a similar situation in Orlando, but I do remember that. But I admire your candidness and tell it like it is personality. It's awesome.
Well, at least tell it the way I think it is. I don't always get it right.
It's all right. So, Alan, you're okay coming back for a part 2?
Anytime.
What do you think, Joe?
Definitely. I still have a list too, so I love it.
Okay, sounds good. So to all of our listeners out there, if you're listening on Apple Podcasts or Spotify, please give us a 5-star rating. And of course, if you're watching on YouTube, please become a subscriber. Alan, we're going to send you one of these Dean's Chat cups. You probably need something to drink more coffee or whatever your beverage of choice is. And I can't wait for the next meeting. I'll email you and we'll get a date and we'll do it again. How's that sound?
My pleasure. It'd be my pleasure.
All right. Thanks so much, Alan. Until next time. Cheers, everybody.
Thank you so much.